Aditya for the opportunity. I will proceed with my talk. Now, there are multiple implant options from the loop to the melt screw to the bio screw and interference screw. But what is the biomechanics behind all these things is, and that is very important, is we have learned that Suchrita has talked about the failure to load Newton about 4,000, 3,500 about the different grafts. But what is about the fixation? It is just about 150 to 500 Newtons. And that is very important because if the fixation has load to failure of 500 Newtons only, so we need to be very slow in our early rehabilitations for initially first 6 weeks. If we don't do so, we will fail on the fixation part. There are 3S concepts for the principles of fixation, and that is, first is it should be strong enough to avoid failure, it should be stiff to provide the stability, and secure to prevent from the slippage. That is what is our goal of ACL fixation. But obviously, anatomic. Sushruta has talked about all these things, and we all know that if the graft is more than 10 mm, a single bundle acts like a double bundle. Key to success is the anatomical tunnels. Sushruta has told about that, and 3S. We all know that anteromedial bundle predominantly acts, it prevents the anteroposterior translation, so it gives us the stability for the drawer test, and posterolateral is for the pivoting. Now, this is a very good point from the arthroscopy journal that anatomic anterior ACL reconstruction, we should consider 2 to 3 points. In spite of the tunnels, there is one important point is that notch width measurement. If the notch width is more than 18 mm, we can use a bigger graft, and we should go for the bigger graft, more than 8 mm preferably. If it is less than 18 mm, we should, because there may be impingement, so we should look for the graft of around 8.5 to 9. Now, the types of fixation. One is the suspensory and another one is the aperture fixation. Suspensory has 2 parts, cortical and cancellous. It is bone to graft area more in the suspensory fixation, so heals nicely. Graft and length can be preserved, bone can be conserved as in all inside technique, but has its own disadvantages. There are 2 types of suspensory fixations. One is the fixed loop and adjustable loop. Fixed loop is the first generation and adjustable loop is the second generation. But what is most important thing is, fixed loop being the first generation, it increases the area of suspension. So graft movement in the tunnel is increased. So even after fixation, final tensioning is not possible. And if we are doing any miscalculations, there can be bungee effect. We'll discuss about the bungee effect. So this is what the bungee effect is. So the graft diameter we have tunneled around 30 mm. The 7 mm, around 7 mm of space, we are creating a dead space there. And that is the suspensory part that will lead to the bungee effect. So what is the bailout option from the bungee effect if we are getting in our cases? To add on extra button, and that we call it as the on button to our fixed loops. It is biomechanically proven to be superior to the adjustable loop devices. Now the adjustable loop, the more advanced part, and it was designed to reduce the dead space. Single and smaller graft can be used. Final tightening after graft fixation can be done. Bone conserving, but adjustable loop is no exception to the tunnel widening, because it is well proven that it lengthens to the cyclical loading and inferior biomechanical stability. So still the gold standard comes to be the fixed loop devices. Now comes the another part, and that is the aperture fixation. It is the compressive type of the fixation, reduces the graft movement, but it also damages the graft. Fixation at the joint level, biomechanically proven to be the more superior construct compared to the suspensory. Now why it is called as the interference screw? Because it interferes the gap between the graft and the bone. That's why it is called as the interference screw. Now factors which are influencing interference screw fixations are the length, size and geometry, divergence of the screw, torque of the screw, bone mineral density and screw material. We'll discuss it one by one. What about the length of the screw? Longer the screw provides better the stability, And in bone tendon bone graft, we have to only engage the bone plug, not the screw. So we can use a smaller length screw also. The size and geometry is well proven, and it is given that increasing screw length improves fixation strength more than oversizing the screw diameter. So our interference screw should come to the tip of our tibial tunnel. What is the ideal interference screw? It should be conical in shape, reverse and blunt threads, and the pitch should be more proximally than the distally, so that it engages the cortical bone. What are the advantages of the bioscrew? We all know that there is no need of removal, doesn't interfere with the MRI, revisions are easier. But there is one very important aspect with the bioscrew, that after 6 weeks, there may be 80% loss of the strength and 60% loss of the stiffness, and tunnel widening is more with the bioscrews because there is resorption started and it leads to the tunnel widening. There are other complications with the bioscrews: breakage, tissue reaction, and fixation lost after the partial degradation. Now, an important concept about the bioscrews or interference screw, whether to use the conical or the cylindrical screw, it is well proven that the conical screws, they perform better than the cylindrical screws. We have to be aware about the screw material. That is very important. Polyglycolide absorbs early, and that's why loses the fixation, leads to the bungee effect as well as the wind viper effect. So crystalline polylactides, which are recently are also called as the PLLA, along with the beta TCP screw, most of them are called as the third generation screws, or we are using most of them. This we have already discussed. Now what about the screw placement? Whether to go for the concentric placement or the eccentric placement, there is no biomechanical difference between the fixations. But definitely, the eccentric one is the preferred one. The reason being, if we put the concentric one, it damages the graft more, first thing. Second thing, we don't get the trajectory for the graft. So what is the ideal screw placement? In the tibia, it is predominantly the posterolateral tract. You can see on the MRI that if you have kept the screw anteriorly, we have loosened the graft, and if you have kept it posterolaterally, the graft length and tension is maintained. Screw insertion torque, it is a very important point, depends on the bone mineral density, tunnel preparation, and directly proportional to the stability. Because our weakest point of fixation is the tibial fixation. Poor bone quality because we are fixing it away from the joint line, which is the weaker bone. Technical tips are very important for tibial preparation, we will discuss it. So what is the key to prepare the tibial tunnel? That we should always use specific reamers while preparing the tunnels. We should use the fluted reamers for the tibia and the flower tip for the femur, because flower tip ones are the bone extractor and the fluted ones, they are the bone impactor ones. That is very important, first thing. Second thing, we should under ream by 2 mm. Supposedly, if our graft diameter is 10 mm, we should ream up to 8 mm only, and then use a dilator so that we compact the bone, so our screw will have a greater torque as well as the greater stability. Divergence of the screw. This is very well known fact and must have happened to all of us. Acceptable limits are 10 to 15 degree. So what is the key point to avoid the divergence of the screw is that always insert the guide wire before inserting, tibial guide wire before inserting the graft, and keep it posterolaterally. Look at the guide wire through the scope so that your screw goes properly. Hybrid fixation. Now the term comes hybrid because the interference and the post fixation both has been shown to have the wind viper as well as the bungee effect. So here comes the hybrid fixation, which is post as well as the interference fixation. But it has not been, scientifically it has not been proven to be more superior to any of the either interference or the post fixations. Now the term we were talking about is that the bungee and the wind viper effect. Bungee is the sagittal movement of the graft and wind viper is the horizontal movement of the graft. So to avoid the bungee and wind viper effect, the tunnel preparations should be under rimmed, and they should be prepared nicely and anatomical, and the screw placement should be perfect. So here comes the modified all inside ACR. In spite of all these things, there was still happening there was still incidence of the bungee effect as well as the wind viper effect. So there comes a modified technique for all inside anterior cruciate ligament reconstruction, and this one is called as upper fix system. So what is upper fix? It is not suspensory. It is not it's like a tenodesis. So this is the system where we pass the tendon through the screw and lock it over the femoral tunnel. The another advancement in this is the exo-shape system. It is an anatomic soft ACL reconstruction through the tenodesis screw in the tibia as well as the femur. What is the ideal strength of fixation? Whether to go for the suspensory with the aperture fixation, or for suspensory above and suspensory below, like all inside ACL reconstruction. And this is the recent paper from 2021. Over the short term outcomes are not different, and they are the same in both the fixation systems. But still, the take home message will be here: prepare tibia properly, be aware of the screw material, femoral suspensory and tibial interference still remains the preferred fixation system. Thank you.